Hi guys, welcome back to week 13. This week we are in gastrointestinal part 2. This week's readings included gastric and intestinal disorders, chapter 41, gallbladder and pancreatic disorders, and chapter 42, cirrhosis and liver failure. And then of course you had your guidelines in CASH to review. And then in COILER you had your x-ray interpretation and your inguinal hernia reduction. So in this lecture, we're just going to really focus on gastric, intestinal, gallbladder, pancreas, and liver, okay? And what the red flags will be for that. And of course, any clinical pearls that will help you in your clinicals as well as for your boards. So in the first slide, I'm just going to do a quick visual video just to go over the basics. You know, I like to bring it back to the basics before we get into lecture real quick.
When you swallow food, it travels through a tube called the esophagus. The esophagus leads into the stomach through a hole in a sheet of muscle called the diaphragm. There's a round muscle at the bottom of the esophagus that works like a valve. The muscle relaxes when you swallow, allowing food to pass into the stomach. Certain cells in your stomach, called proton pumps, release acid to help digest the food. The lining of your stomach protects it from the acid. The esophagus has a different type of lining, which looks like it's made of smooth tiles. The valve is designed to close tightly after you swallow, so nothing comes back into the esophagus. Your diaphragm is also meant to pinch securely around the esophagus, closing off the opening to your stomach. It's normal for a small amount of acid to occasionally splash into the esophagus. This is called reflux. That word means flowing back. A small amount of reflux doesn't usually cause any harm. But if acid splashes up into the esophagus over and over again for years, the esophagus can be damaged. There are several reasons this might happen. It's not uncommon for the valve to become weaker, so it doesn't close tightly. That allows acid and partially digested food to come up into the esophagus. Sometimes the diaphragm weakens around the esophagus, allowing the hole to become larger. This hole is called the hiatus. When it becomes larger, part of the stomach may bulge through it. This is called a hiatal hernia. The hernia may cause the esophagus and the valve to move up. In that case, the diaphragm is no longer reinforcing the valve. That makes it more likely that acid will get into the esophagus. When acid and food splash up into the esophagus repeatedly, it's called gastroesophageal reflux disease, or GERD. Gastro for the stomach, or gastric system. Esophageal for the esophagus. Mayo Clinic's Division of Gastroenterology and Hepatology is recognized as #1 by U.S. News and World Report. Go to mayoclinic.org to find out how to request an appointment with a Mayo Clinic physician.
Okay, so hopefully that was helpful because this is going to be the logistics of our, or the basics of our lecture for today. So the first thing we're going to get into is gastroesophageal reflux disease. I'm sure you've all heard of this, aka GERD. Okay, let's talk about the epidemiology and causes. So in general, just so we're aware, it's a lifelong condition. The primary cause is sometimes inappropriate, spontaneous, transient relaxation of the lower esophageal sphincter to an unknown stimulus, and it can cause mucosal damage and, of course, serious consequences. The risk obviously increases with age, definitely comorbidities, obesity, and a BMI greater than 25. You have a lower risk if you're over the age of 69 and you haven't already been diagnosed. It's equal in male and female, so that's not really anybody has it more than, or male doesn't have it more than female, it's equal. Many food and drug sources that decrease the lower esophageal sphincter pressure are alcohol, caffeinated and decaffeinated beverages, chocolate, citrus, fatty foods, fats, including butter, margarine, and shortening, and oils, onions, peppermint, and spearmint, and tomatoes. So be very conscious of being aware of these foods because these are the foods you need to tell the patients who are suffering from GERD to avoid. You know, again, alcohol, caffeinated and decaffeinated beverages, chocolate, citrus, fatty foods, fats like butter, margarine, and shortening, oils, onions. Onions is a big one. Peppermint and spearmint and tomatoes, all very acidic inflammatory foods. that will exacerbate their GERD. Okay, GERD can be very painful, so you really want to make sure you have the patients avoid these foods. Anticholinergic, beta blockers, calcium channel blockers, diazepam, estrogen, progesterone, nicotine, including secondhand smoke and theophylline, also decrease the lower esophageal sphincter pressure. So just be aware. So it's a subjective in terms of symptoms. Subjective symptoms include regurgitation, like water brash type reflex salivation. That's what they're going to taste in their mouth. They get complaints of heartburn, burning, belching, dysphagia, sour taste in the mouth, especially in the mornings, belching, substernal or retrosternal chest pain, and coughing. The GERD definitely worsens after reclining after eating a large meal, ingesting alcohol, chocolate, caffeine, fatty or spicy foods, or nicotine. So smokers of all kinds, any kind of inhalation of smoke definitely can worsen GERD. So just be conscious, it's not just nicotine, anybody who's vaping, and it doesn't matter what's in the vape itself can definitely worsen GERD. So just make sure you tell that to your younger population, 40s, 30s and 40-year-olds. I'm finding a lot of vaping. Okay. Wearing constrictive clothing or working in an occupation in which heavy lifting, straining, or working in a bent over position can definitely exacerbate GERD as well. Atypical symptoms include adult onset asthma, chronic cough, chronic laryngitis, sore throat, or non-cardiac chest pain. So those are atypical symptoms, but also could be associated with GERD. Objective are usually normal. They may have a positive occult blood on the rectal exam from microhemorrhaging in the irritated esophageal epithelium. In terms of diagnostics, the diagnosis is made by history alone in about 80% of patients. So most of your patients are just telling you their symptoms, and based on what they're telling you, you're making that diagnosis. If the patient fails to respond to treatment with daily protein pump inhibitors, you may request an upper endoscopy to visualize the mucosa. The benefit of detecting Barrett's esophagus or esophageal strictures or cancer. So keep in mind, patients that have GERD and are left untreated are extremely high risk for Barrett's esophagus and esophageal cancer. So just be conscious of making sure these patients' symptoms are well managed. They avoid the foods they're not supposed to. They hopefully make some lifestyle changes, quit smoking, quit vaping, and they take the medication. So differential diagnosis you want to definitely consider in terms of diagnosing GERD is peptic ulcer disease. And in peptic ulcer disease, the pain is usually relieved by food. So that's how you can kind of differentiate them. Cholelithiasis or cholecystitis, usually associated with high fat meals, and it's usually epigastric or right subcostal pain. And there's also nausea and vomiting associated with that. Angina and myocardial infarction, angina is relieved by nitrates, and calcium channel blockers, beta blockers, and nitrates decrease the LES pressure and can produce coexistent esophageal reflux. So just be careful to make sure you differentiate whether it's GERD versus angina. So the goal of treatment with GERD is to rapidly eliminate or reduce the symptoms. You want to prevent the meal or eliminate meals that are going to exacerbate the symptoms or exercise related symptoms. You want to prevent complications of an esophageal stricture, esophageal ulcer, Barrett's esophagus, pulmonary aspiration, and esophageal hemorrhage. Okay, these are definitely things we want to avoid. So that's why we need to deal with GERD before it gets to this point. Lifestyle modifications include weight loss. You want to make sure the patient is elevating the head of the bed 6 to 8 inches and avoiding meals 2 to 3 hours before bedtime. You want to avoid certain trigger foods, especially chocolate, alcohol, caffeine, acidic, or spicy foods. You want to make sure the patient is referred to GI for an endoscopy, yearly visit, follow-ups. And you definitely want to make sure you're following up with them to review if they've made their lifestyle changes, how their symptoms have been alleviated, and if they're, taking their medication as prescribed. So treatments, the PPIs take 30 to 60 minutes before breakfast to maximize effectiveness. Mild to moderate symptoms with no esophageal erosion, an 8-week course of a PPI once a day before the first meal of the day. It's treatment of choice, okay? Partial response, you want to tailor to the patient, like take the PPI at night for nighttime symptoms or twice a day dosing change to, if you need to change to a different PPI if they're not getting the response they need. Severe erosive esophagitis, Barrett's esophagus, and peptic stricture, or those on BID dosing, the PPI should be maintained on long-term therapy. So these patients who have consistent symptoms all the time and have the diagnosis of the erosive esophagitis or the Barrett's esophagus, they need to be on a daily dose for pretty much the rest of their life. So you want to recommend, which is not always seen in practice, that you follow up with the patient on long-term PPI every 6 months to assess PPI-associated pneumonia, C. difficile, osteoporosis, and vitamin deficiency. So keep in mind there are side effects that go along with these PPIs that you need to make sure you're monitoring your patient for, especially if they're on the long-term therapy. So every 6 months, you want to assess for any pneumonia, any C. diff, any signs of osteoporosis or vitamin deficiency, and also educate your patients about this to make sure that you're warning them about signs that they need to report to you if they notice any changes in these particular areas. So here are your prescribing considerations and the medications to consider. So in terms of PPIs, your proton pump inhibitors. Okay, these are the ones that you're looking at for mild to intermittent symptoms. Very important chart. Keep this handy. This is pretty basic. Omeprazole, 20 milligrams once a day. You want to trial it for 4 to 8 weeks. Take 30 minutes before breakfast. You want to go over the side effects. Again, C. diff is a major side effect that they need to make sure they report to you if they do experience. And then in terms of moderate symptoms or partial response to once daily dosing, again, these are your choices that you can go with. Omeprazole and pantoprazole, I have to say in practice, is pretty consistently what I see prescribed. These are the two most common, omeprazole and pantoprazole, for sure. All right. All right, GERD. So we're unresponsive to the treatment. So what do we do next? We refer to the GI, of course. They may need to consider surgery, newer treatments, and procedures. But again, even if they're responsive to treatment and you're finding that this is a patient you're going to need to probably follow up with for a long period of time, because the likelihood is they're not going to really make a lot of lifestyle changes, or you don't see them being that compliant with their medication and you're concerned they're high risk for cancer. Like these people, you should go ahead and make the referral to GI. Because remember, when you do make these referrals, keep in mind that, sometimes you don't get an appointment for a month at minimum, so you want to just go ahead and start that, that referral and that, just that process, so that nothing, suddenly erupts and there's no plan in place. So again, refer to GI for endoscopy or those not responding to the basic PPI therapy. If the endoscopy reveals Barrett's esophagus, which is a precancerous condition, they will definitely need more frequent endoscopies. They want more follow-up because we want to make sure this doesn't get worse. In terms of patient education, again, reduce weight, quit smoking, avoid triggers. In terms of quitting smoking and avoiding triggers, again, the vaping, big thing right now. So quit vaping, and also the alcohol, big deal in the world, especially down south, a lot of drinking. So just make sure you're educating your patients on how that can definitely trigger this particular diagnosis. So Barrett's esophagus and esophageal disease. So now we've moved from just basic GERD to precancerous condition of Barrett's esophagus. Okay, now we're in trouble. Okay, Barrett's esophagus is thought to be a risk factor for esophageal cancer. It's pretty consistently, when you see esophageal cancer, they've already had this diagnosis. So I don't know why it says it's thought to be a risk factor. I'm pretty sure it is. Columnar epithelial metaplasia is found on endoscopy. The higher risk patients are white, Hispanics, males, older, and smokers, of course. These patients require more frequent endoscopy for monitoring. Treatment is aggressive with acid suppression, because remember, the acid is what's producing these conditions. Like this constant acid against the esophagus is what's producing these problems. So we want to make sure we suppress the acid's production so that it doesn't worsen it. So PPIs and surveillance with an endoscopy and follow up with the GI doctor, of course. Esophageal rupture is rare, but it does happen. It's you want to consider it whenever you hear a patient with chest pain, epigastric pain, free air in the abdomen, mediastinum, and crepitus. And then, of course, esophageal cancer. You want to think possibility of cancer in GERD unresponsive to PPI. So Again, GERD is a big deal. Like, we need to get the acid under control. Like, that is a big deal. I can't stress this enough. They stressed this a lot when I was in grad school, and I never really understood why they made such a big deal about it until I started to practice and I started to see how quickly GERD can evolve into cancer if it's left untreated. So you want to think always in terms of a GERD. If the patient has got these symptoms and it's still severe, they're unresponsive to the PPI, suddenly the heartburn is getting worse, suddenly the patient is losing weight, you definitely want to consider esophageal cancer. That's why it's such a good idea to have your patients with GERD see the GI specialist for routine and follow-up endoscopy with biopsy, so they can make sure to treat this very aggressively and very quickly. Peptic ulcer disease. So here we're talking about duodenal and gastric ulcers. The hallmark of peptic ulcer disease, or PUD, is a burning or gnawing hunger sensation or dyspepsia in the epigastrium, which is often relieved by foods or antacids. So the subjective pain is clustered and episodic. This pattern is more diagnostic than just having pain itself. So that's important to know. So it's clustered and episodic. So that's important to know in particular for this diagnosis. If the pain is specifically clustered and episodic, all right? So the response to food helps differentiate the ulcer. So if the pain is relieved by food, you want to think duodenal ulcer. If it's worsened by food, you want to think gastric ulcer. Okay, there's also complaints of nocturnal pain, which is due to the circadian release of gastric acid. So when more acid is released, their pain increases. So at night, with circadian rhythms, they release more gastric acid, and there leads to more nocturnal pain. On objective exam, you're seeing some mild epigastric tenderness, melena or positive occult blood in the stool if bleeding. Otherwise, it's a normal exam. You may have positive peritoneal signs with a rigid abdomen. If you have signs of an acute abdomen, you want to think about, consider that it might be a perforated ulcer. So the PUD diagnostics, H. pylori gastritis in 90 to 95% of both duodenal and gastric ulcers that are not associated with NSAIDs. So it's a lot of the times H. pylori gastritis. And that H. pylori infection increases with age. And worldwide, 30 to 50% has been colonized, but it's an unknown mode of transmission. There are 4 tests to detect H. pylori. That includes fecal antigen assay, urea breath test, a biopsy with a histological exam, and a serological antibody or enzyme-linked immunosorbent assay least sensitive test. Okay. Diagnostics, the standard diagnostic for PUD is an endoscopy, because they want to directly visualize and biopsy that esophagus. Okay. You're definitely looking at your CBC, you're looking for anemia. Is there any bleeding? You want to consider that. If there's an increased white blood cell, you want to consider perforation. You may see other blood work if it's unclear of the diagnosis or as condition warrants. You want to check the fasting serum gastrin level. If there is an increase in gastrin suspected, if it's elevated, you want to think the Zollinger-Ellison syndrome. You want to consider that in your diagnostics. Okay, so in terms of differentiating duodenal ulcers versus gastric ulcers, so duodenal ulcers are common more in 30 to 55 years of age. There's a dramatic drop in duodenal ulcers due to the eradication of H. pylori, so that's positive. Episodic and clustered pain, nocturnal pain is what you see in duodenal. Again, there's a reduction in pain after eating. Very important to remember that, okay? A reduction in pain after eating in a duodenal ulcer. It's usually benign, so it's not such a big deal. Gastric ulcers, common in 55 to 70 years old. There's an increased prevalence in gastric ulcers due to the increased use of NSAIDs and low-dose aspirin. So you're going to see gastric ulcers more frequently than duodenal. Just keep that in mind. 50% of NSAID-related ulcers are asymptomatic. Interesting. So just keep that in mind. Find out what your patient is taking in terms of over-the-counter medication. Not only what are they taking, how often are they taking it? And tell them to be honest, because it will really help you differentiate what your diagnosis is here and your cause. In terms of gastric ulcers, you're looking at episodic cluster pain and pain that worsens after eating. Again, you get nocturnal pain, nausea, and anorexia, because remember, they don't want to eat. because it hurts to eat. So, with gastric ulcers, you're going to see a weight loss. You're going to possibly see vomiting, weight loss. You're going to definitely suspect gastric cancer. And in 3 to 5% of these patients, it is cancerous. So again, make sure you follow up, figure out what's going on, what's the cause, and make sure you treat them. So differential diagnoses includes thoracic and upper abdominal disorders, cholecystitis, pancreatitis, irritable bowel syndrome, GERD, gastric cancer, gastritis, and gastroenteritis. Remember, red flags: if the pain is unresponsive to food or antacids with severe pain and rebound tenderness, the cause is likely not an uncomplicated ulcer. You want to think perforation or other organ disease. If you see weight loss, anemia, or exacerbation of the pain when eating, gastric cancer should be suspected. Okay. Anytime you see weight loss and anemia, you always want to consider cancer. Get some blood work. That's the first step. Get blood work immediately. Okay. So the aim of management, you want to relieve pain. In peptic ulcer disease, we want our aim of management, our goals for these patients are to relieve their pain, heal the ulcer, and prevent complications or reoccurrences. So non-pharmacological, again, can't stress this enough, smoking cessation. Cigarette smoking increases the risk for peptic ulcer disease in patients with documented ulcers. It impairs healing, promotes reoccurrence, and increases the morbidity and mortality of this particular patient. So I can't stress enough, they've got to stop smoking. That's number one. Again, stop vaping. And number two, again, is the drink. Alcohol is an inflammatory drug, and it will make this worse as well as make their symptoms worse. So again, dietary, avoid foods that precipitate dyspepsia. Pharmacologically, we need to look at table 40.2 for the pharmacological treatment. H2RAs and PPIs and agents that enhance the mucosal defenses, example, antacids like carafate or Pepto-Bismol or misoprostol, as well as antibiotics can do that. PPI are the drugs of choice for treating peptic ulcer disease. PPIs heal 90% of duodenal ulcers in 4 weeks and 90% of gastric ulcers after 8 weeks. Long-term use associated with slightly decreased absorption of vitamin B12 and iron. So just talk to your patients about that and give them some information about foods they should increase in their diet to help get a little bit extra B12 and iron in their diet in terms of certain vegetables. The PPI, a duration of greater than 24 hours and once a day dosing schedule. The usual dosing is omeprazole 20 milligrams, rabeprazole 20, lansoprazole 30, esomeprazole is 40, and so on and so forth, pantoprazole 40. H2RA is for mild symptoms and no indicators of complications. So they can go on empiric therapy with H2RA instituted for 2 weeks. If the symptoms persist or worsen, you want to consider an EGD for definitive diagnoses. You want to administer this H2RA once a day at bedtime or half the daily dose twice a day for 8 weeks. More than 80% of ulcers are healed by the completion of this regimen. Please make sure you educate your patients when you're instructing them on taking this medication. Remind them that this is actually going to heal their ulcer. It will make it go away. That might give them a little more incentive to be compliant in taking it. So just again, remind them not only is it going to heal it, but they don't have to take this forever. It's just for the 8-week period. Most patients generally tolerate it well. Tagamet, for instance, inhibits the hepatic cytochrome P450 system and can elevate the levels of other medications such as Coumadin, Theodore, and Dilantin. So just be very conscious of that. Other H2RAs have fewer adverse effects. So just consider what other medications your patient is on before you prescribe. In terms of antacids, there are disadvantages. They require more frequent intake, like 1 to 3 per hour. You want to be very careful in your renal patients due to the risk of aluminum and magnesium toxicity. You want to avoid calcium-based antacids in peptic ulcer disease, as calcium causes rebound acid secretion. So be very careful with them. In terms of sucralfate, it enhances mucosal defense, and it's used in healing duodenal ulcers. Long-term treatment is used with sucralfate to prevent reoccurrence, and it forms like a protective barrier. So that is prescribed 1 gram 4 times a day, and it heals duodenal ulcers as well as with the H2RA. So Pepto or Pepto-Bismol has antimicrobial action against H. pylori and has been shown to eradicate the organism in up to 33% of cases. You want to take caution with salicylate in terms of black stools, and diabetics potentiates meds causing hypoglycemia. Okay, so treatment for peptic ulcer disease. So misoprostol or Cytotec, it's a prophylactic that prevents gastric ulcer for patients on NSAIDs. All right, it's ineffective in preventing duodenal ulcers caused by NSAID use, and we do not use this in pregnancy because it can cause abortions, premature birth, or birth defects. So be very careful. So keep in mind, a lot of your pregnant females definitely get a lot of reflux. So you want to be very careful in terms of prescribing that you make sure you're looking at anything that is not appropriate for women who are pregnant. H. pylori eradication with combination of your Pepto-Bismol, your antibiotics, and your PPIs for 2 weeks. That's your standard triple drug therapy with a combination of 2 antibiotics, including clarithromycin and either amoxicillin or metronidazole, with a PPI all twice a day for 14 days. So that's your standard prescribing for your treatment in peptic ulcer disease when it comes to eradicating H. pylori. 75 to 90% of those are effective in eradication of H. pylori. Amoxicillin is preferred over metronidazole due to the resistant strains of H. pylori. Remember, there are different strains we're dealing with. That's why we have to use this combination of drugs to eradicate it. There's adverse effects of metronidazole, which hamper patient adherence. Okay, so side effects suck sometimes for these patients. You just try to, give them support, see if they can handle it, and stick through it. Obviously, if it's nothing major, because these drugs really do work, and we want to try to get rid of this as soon as we can for these patients. Bismuth salicylate and 2 antibiotics may be used, but QID dosing and increased incidence of adverse effects. So obviously, the more frequently you give the medication, the more frequent they're going to have, side effects or adverse effects. So, you want to try to not have to do that. You have standard quadruple therapy, which is 14 days of a PPI BID, bismuth subsalicylate 2 tabs QID, and tetracycline QID and metronidazole TID. That's a lot. But, if you have to do it, that's what the next step would be. So in terms of follow-up and referrals, you want to have the patient follow up 4 weeks after completion of the therapy, or any time in between if they're having trouble completing the therapy because of the adverse effects, or if their symptoms are worsening. Okay. Non-H. pylori associated ulcer disease follow-up is necessary only if the symptoms reoccur. If after 2 weeks there's no improvement or symptoms worsen, you want to refer the patient to GI for an upper endoscopy, if the GI also recommends that it's indicated. Anytime there's a gastric ulcer suspected rather than a duodenal ulcer, you want to refer to GI due to the high incidence of gastric cancer. Again, I can't stress this enough. These patients who have any kind of upper GI symptoms, their symptoms, if left untreated, will lead to any kind of cancer very quickly. So you want to follow up, you want to treat, and you want to make sure these symptoms are managed very quickly and efficiently. Okay, hemorrhoids. So where are our risk factors for hemorrhoids? Who are at risk? These are patients who are deficient in dietary fiber. They have increased straining during defecation. Any kind of hereditary 10% of the patients with hemorrhoids have a family history. Patients with illnesses characterized by chronic diarrhea, such as IBD, inflammatory bowel disease, are likely to develop hemorrhoids because of the constant going. Really irritates that wall and can lead to hemorrhoids. Risk of hemorrhoids includes constipation, prolonged sitting, pregnancy, and anal infection. A lot of times you'd be surprised, we see the anal fissures, anal hemorrhoids, anal issues a lot in bus drivers. So just keep that in mind, and especially with the ones that are at high risk who are obese or have an elevated BMI. Those are your patients you would definitely see hemorrhoids in. Subjective would include any abrupt onset rectal pain associated with the development of a perianal lump, more intense pain after defecation, straining pruritus, or perianal skin tags. Internal hemorrhoids present with rectal bleeding, described as bright red streaks on the toilet paper or blood drips into the toilet after a bowel movement. Occasionally, the bleeding is sufficient enough to cause anemia, which in any case merits further investigation. I'm sure you've all seen hemorrhoids in your patients. Visual inspection of the anal area. Obviously, it's thrombosed hemorrhoids, shiny blue masses at the anus. Skin tags may be visible at the site of resolved hemorrhoids, fibrotic and painless. A digital rectal exam is not an accurate means of diagnosis, as most internal hemorrhoids are soft swellings, not usually palpable or painful unless thrombosed, infected, or unless a fissure has developed. External hemorrhoids usually can be diagnosed at a physical exam. Internal hemorrhoids are visible on physical exam only if they have prolapsed. A definitive diagnosis requires an anoscopy for proper inspection of the anal canal. With the anoscope in place, the patient is asked to strain as with a bowel movement so that the degree of prolapse can be assessed. They may undergo a proctosigmoidoscopy to effectively rule out any precipitating or coexisting diseases of the rectum or colon. So obviously you're not going to be doing this. You just need to be aware of what that procedure entails, or that, if that's what the patient will need to be referred for, just so you can educate the patient and give them the heads up as to what's to come. So the classification of hemorrhoids, to remember, it's classified in terms of severity, 1st degree versus 4th degree. 4th degree is, protrusion beyond the anal canal, and you see a prolapse despite attempts at manual reduction. So that's the worst one you can have. 1st degree, you're just seeing a protrusion into the lumen of the anal canal, usually without the sensation of protrusion. So here's just some diagrams of an internal external hemorrhoid and what an anoscopy would look like. So they just put a speculum in there. It's not exactly comfortable, but internal hemorrhoid versus external hemorrhoid. Remember, for these patients, the preparation age, wipes, cream, that kind of thing. So a differential diagnosis includes polyps, carcinoma of the anus, anal rectal fistula, cryptitis, papillotitis, or rectal prolapse. A proctosigmoidoscopy is an effective means of establishing the appropriate diagnosis. In terms of treatment, some are asymptomatic and no treatment, or some result in profuse bleeding, which requires an emergency ligation. You want to focus on pain control with these patients. They're very uncomfortable. Sitz baths for sure. And you want to educate them on how to use a sitz bath, because a lot of people, they don't know. They just buy the thing and they're like, what do I do now? If hemorrhoids do not spontaneously regress, the care is directed at decreased straining with defecation and modification of toilet habits. So you want to avoid sitting on the toilet for long periods of time. They want to use a bulk formin laxative. They want to increase their daily fiber intake slowly to 25 to 35 grams to establish regular form stools. If they're having diarrhea, you want to definitely treat that accordingly to control the frequent loose stools, because that will definitely make the hemorrhoids and the pain worse. In terms of pruritus, you want to maintain anal hygiene. So this is a big deal. Okay. Nobody likes to talk about it, but it's very important, especially in terms of dealing with hemorrhoids. The patients you're seeing a lot of times with anal issues, especially hemorrhoids in particular, fissures, abscesses, that kind of stuff, are usually obese, a lot of the times very big, a lot of the times very hairy. So these patients really need extra education on how it is that they're supposed to maintain their anal hygiene. It's hard for them to reach. It's hard for them to see. They can't always get through the folds. They have to be shown like how it is they clean. Make sure they're using a washcloth. Make sure they're really getting in there with warm water and soap and rinsing. If they need to use the shower head to help rinse down there, that's a really good way to help with hygiene. If they don't have a shower head, they may need to buy one. Like, it's that serious to, prevent these things from getting worse. And anal itching, the pruritus, definitely can make pain worse, because then they start scratching. It's a whole sanitary thing. So those are things you really want to educate. Maybe get them like a peri bottle where it sprays down there every time they use the bathroom. They can use that to spritz themselves like down there. They do sell toilet seats with bidets now that are actually quite wonderful if you're into that, or they can afford that. That's great. But they really need to be educated on the importance of hygiene. So if they're having a lot of loose stools, just make sure they're showering frequently and using that shower head and really rinsing down there. Sitz baths, witch hazel, and application of topical hydrocortisone creams are also very good in terms of controlling the pruritus. But again, I can't stress enough, usually the reason for the pruritus is that they're not cleaning well down there. So wipes with witch hazel are also extremely effective. If the external hemorrhoids are painful despite treatment, we want to refer for surgical excision, which should be made. So again, first degree hemorrhoids, in terms of treatment, they're injecting sclerotherapy or infrared coagulation. Second and third degree hemorrhoids are treated with rubber band ligation, in which a rubber banded ring is placed around the base of the hemorrhoid, and they basically just tie a rubber band around it and cause the blood flow to stop. All non-surgical techniques are associated with some degree of pain and bleeding, of course, and large advanced degree hemorrhoids will most often require referral to a surgeon for a formal hemorrhoidectomy. Excision of a single external hemorrhoid, evacuation of a thrombosed external hemorrhoid, and injection sclerotherapy of simple internal hemorrhoids with additional training. Otherwise, you're going to make a GI referral. So all of these procedures, obviously you're not doing. Again, the important thing is to learn what the procedures entail in terms of first degree, second degree, third degree hemorrhoids. Okay. Abdominal hernias. Okay. So abdominal hernias, the most common in men and women are groin hernias. In indirect, it's the most common. In direct, it's older men and congenital, and from femoral, it's women. Women are most common in there. We have ventral or abdominal hernias. In terms of epigastric, men's more than women. Sometimes it's in newborns. We have incisional and umbilical. So further risks associated with anything that increases abdominal pressure. So how do we put abdominal pressure and cause abdominal hernias? Basic things like coughing, heavy lifting, and obesity. These are all things that put a lot of stress and pressure on the abdomen and can lead to abdominal hernias. Subjective symptoms would include pain or popping with strain or lifting, and a noticeable or palpable bulge. You want to review the physical exam for hernias. A male exam is to be reviewed in week 13. So make sure you know how to do the physical exam for hernias. In terms of objective, you're going to do an abdominal and genital exam, include scrotum, invaginating cord, testicles, or femoral canal. You want to do a scrotal exam for hernia. Okay, so check the scrotum, make sure nothing is bulging. And ask the patient too, do they feel anything abnormal in their scrotal area? And if they are shy about talking about it, just say, listen, we have to check because we just want to make sure there's no hernias. You must determine whether the hernia is incarcerated or strangulated. Very important. So here are some great images of the different types of hernia. We have upper epigastric hernia, which is in your upper abdomen at the midline. Incisional, which is at the site of a previous surgical incision. We have umbilical, which is right at the navel. I've seen that a lot, especially in obese men. We have direct inguinal, which is near the opening of the inguinal canal. We have indirect inguinal, which is at the opening of the inguinal canal. And then we have femoral, which occurs in the femoral canal. So inguinal versus femoral. You want to make sure you really differentiate those two because that's a big deal. So inguinal hernia is a little bit up here. Femoral is it's more and more closer in here. All right, so just be conscious of that. Diagnostics is usually by physical exam. You may see an ultrasound or films. Differential diagnoses can include hydrocele, psoas abscess, femoral adenopathy or inguinal adenopathy, and ectopic testes. Management, of course, you want to refer to a surgeon. Depends on the patient's presentation, comorbidities, and any other lifestyle things. The patient may be a candidate for reduction where the hernia is pushed back into place. A lot of people do that on their own. My fiance had a inguinal hernia, that he just pushed it back into place every time it popped out, and usually it popped out after he worked out, until he was kept pushing it back in and it just wouldn't go back in. That's when it was time for the surgical repair. Obviously, you don't want to wait that long. You don't want to tell your patients to do that, but that's how he handled it, unfortunately. Anyway, patient education should include if there's increased pain, nausea, vomiting, or fever, they need to be seen urgently, because it suggests strangulation, of course. So you definitely want to make sure you tell them, just like my fiance who decided to wait. Um, the things that you're looking for, that would indicate an emergency is if there's increased pain, nausea, vomiting, fever, there's a concern that the hernia will strangulate, and that's what you have to make sure you educate your patients who put it off this surgery because they don't think it's an emergency, that's one of the biggest risk factors with just leaving it alone is the strangulation. So next we're getting into irritable bowel syndrome. So we really want to make sure we focus on the criteria to diagnose the IBS. Just so you know, that's one of the things I want to focus on in this particular lecture. Just make sure you learn that. It's a functional GI condition characterized by abdominal pain or discomfort and a change in bowel habits. Keep in mind, in terms of diagnoses, 2 of the following features must be present. They must have abdominal pain or discomfort that is relieved by defecation, like when they go to the bathroom, it feels better, the change in frequency in stool, and the change in the appearance of the stool. So 2 of these things must be present in order to be diagnosed with IBS, all right? Change in the appearance of the stool, change in the frequency of the stool, or abdominal pain or discomfort that is relieved by going to the bathroom. Criteria to diagnose IBS, again, here it is. Here's your nice little chart to remind you: altered stool frequency, altered stool form, including hard, loose, watery, or mucoid stools, passage of mucus, varied degrees of bloating and abdominal distension, and there's defecation with varying patterns of constipation and diarrhea 25% of the time. Okay. Risk factors, it was originally thought that it was women were greater than men, but it's likely that men were just underdiagnosed. It usually first presents in late adolescence and early adulthood, but rarely in patients older than age 50. It may be associated a lot of times with psychiatric diagnoses like anxiety, depression, somatoform disorders. You see a lot of the times people with anxiety and depression have bowel issues. Okay, just if your patient has the comorbidities of anxiety, depression, or somatoform disorders, you automatically want to consider IBS if they are coming in with any kind of GI complaints. All right. A recent stressful life event often precipitates IBS symptoms such as marital discord, death, or abuse. The exact pathology or mechanism is unknown, but it's pretty obvious when you have anything that's causing a lot of stress or anxiety. It can definitely affect a patient's bowels. Pearl or red flag to know in terms of clinical stuff. A change in bowel habits and abdominal pain in an older adult is not likely new onset IBS. Keep looking for a diagnosis and definitely rule out colorectal cancer. Again, if your patient is over the age of 50, they're not going to just suddenly have a new diagnosis of IBS. That's not really a thing unless they have a new sudden, stressful event. That's the only thing I could consider in that case. But otherwise, most likely something else is going on and you want to keep looking for a diagnosis, especially you don't want to miss any kind of colorectal cancer. Okay. IBS typically presents in one of 2 ways, either with abdominal pain, altered bowel habits consisting of both diarrhea and constipation, and or painless diarrhea. So one subjective symptoms you could see is that the pain varies: burning, sharp, dull, diffuse. Left lower quadrant is common. It usually does not interfere with sleep. It's often precipitated by eating stress or relieved with a bowel movement or passing gas. They complain of abdominal distension, gas, belching, usually about 2 hours after a meal, often thought to be related to food intolerance. It's also complaining of urgency to defecate, bloating, gas. They may complain of dyspepsia and heartburn, nausea, and vomiting. Another subjective thought patient you could see is painless diarrhea, complaining of need to defecate immediately on awakening or after eating. Rarely occurs nocturnally. Urgency may cause incontinence. So the bottom line is, in IBS, irritable bowel syndrome, alteration in bowel habit is the most consistently reported symptom. It's usually diarrhea alternating with constipation. The constipation was previously responsive to laxatives, and now it's continuous, and the stool is harder and may be decreased in caliber. Mucus is likely present in the stool. It shouldn't have blood except for incidental finding with hemorrhoids. If the blood is present as a regular symptom in the stool, we want to consider an inflammatory disorder or other diagnoses. Okay. Blood is not a common, consistent thing in IBS. That's really more hemorrhoids or something else is going on. So don't associate IBS and blood. That's not good. Okay. Objective, usually normal, may have tenderness in some area of the colon. Example, the left lower quadrant over the umbilicus or epigastric area. DRE are normal but may reveal tenderness, may exacerbate symptoms. Usually there's no associated weight loss or deterioration in health. You want to look for a history of psychosocial stressors correlated with the onset of symptoms. The key to diagnosis in irritable bowel syndrome is the lack of other systemic symptoms, such as fever, leukocytosis, or bloody stools, which might suggest an organic cause for the symptoms. Okay, again, I'm going to repeat that. In irritable bowel syndrome, the key to diagnosis is the lack of other systemic symptoms, such as fever, leukocytosis, or bloody stools, which might suggest an organic cause for symptoms. So a different cause, you know. All right, diagnostics for irritable bowel syndrome, we're looking at their CBC, ESR, chemistry panel, serum amylase, urinalysis, and stools for occult blood, very important. O&P and cultures, okay? Laboratory findings that support a cause other than IBS include elevated ESR, anemia, leukocytosis, blood or white blood cells in the stool, or stool volumes greater than 300 mLs. Okay, remember, blood, you know, any sign of bleeding or blood or elevated ESR, like this is not a common thing for IBS. So then you know it's something else, it's not IBS. A flexible proctoid sigmoidoscopy for age 40 or older. You want to do a colonoscopy. You want to check for food intolerance testing, especially lactase deficiency. A lot of people are allergic to lactose, you know, milk. So if they're drinking milk and they're having this reaction every time they go to, you know, drink milk, they have to go to the bathroom. Be good to know. Let's check that. And then they stop eating it. Suddenly they feel better. That could really make a big difference in their lives, as well as prevent them from having to go for an excessive amount of testing. So it's a very easy test. It's a hydrogen breath test or lactose tolerance test. You also want to do some celiac testing for in terms of food intolerance. And if we have a lot of diarrhea, we're looking at their thyroid testing. We want to do a 24-hour stool check for fecal fat and stool weight, and stool testing for laxative content. In IBS, you're going to look at differential diagnoses. There's a lot of different differentials. You always want to consider the organic causes again, especially if you see bleeding in either the lab work or bleeding in terms of their bowel movements. You want to consider infectious processes or inflammatory disorders such as Crohn's or ulcerative colitis. Okay. Management, you want to make the diagnosis, identify the symptom pattern, and based on the symptom pattern, therapy may include diet, education, and pharmacological and supportive intervention. So again, what are we doing with our patients with IBS? First of all, we're clarifying and making sure we're confirming the diagnosis is actually IBS and not some other organic cause. We're identifying the symptom pattern. You know, what's triggering it? You know, have we really come up with some real basic stuff that we can see would cause them to go to the bathroom, and how often and how frequent? Like we've kind of narrowed down their symptoms, right? And based on what their symptoms are showing us, then we decide how we're going to treat. So we treat with diet modification. We cut out things that are obviously triggering it, or we make their meals more frequent and less big so that they're not having to go so often, so frequent, you know, whatever works for the patient. We talk about education. We talk about pharmacological and supportive intervention. So make sure they're hydrating, make sure they're avoiding trigger foods, make sure they are taking whatever medications will work for them if they need anti-diarrhea versus laxatives. In terms of patient education, there's no proven treatment, and that the therapy is often symptomatic. So we're really basing our management of this diagnosis around the patient's symptoms, because you can't really get rid of it, unfortunately. IBS is often confused with lactose intolerance. So you want to evaluate by removing lactose from the diet for 2 weeks and monitoring the symptoms. So if the patient cuts out dairy for 2 weeks and finds that they're no longer running to the bathroom, that might be the cause as opposed to it being irritable bowel syndrome. A high fiber diet can be beneficial regardless of the predominant bowel habit. You want to increase the fiber intake to 20 to 30 grams a day, and at least 8 ounces of water daily, or 8-ounce glasses of water daily, as well as exercise and a dietary referral to a nutritionist. You know, keep in mind, we are nurse practitioners, we are holistic minded. So that is one of the benefits of seeing a nurse practitioner as opposed to a doctor, a PA, or any other practitioner. The idea of referring your patients to a nutritionist or dietitian is fantastic. I would love to be able to do that every time anything came up. But unfortunately, as in my practice and in the practices that my colleagues are in, that's not really a thing. If we can get an appointment, it's really more for our renal patients that we focus on because the availability is just so limited. So keep in mind, it's really important as nurse practitioners that you incorporate into your education for your patients, not only for IBS, but for all these diagnoses, the appropriate management with dietary concerns, and making sure you're educating them on the appropriate food. So yeah, you say to them, we need to increase your fiber to 20, 30 grams a day. Well, how do they do that? What has fiber in it, right? So having resources or tools or just being able to tap into a website that you can share with them to give them some options in terms of increasing fiber is something you really want to make sure you offer to your patients in terms of treatment, and just giving them options and education to really help themselves heal. Obviously probiotics have moderate evidence in support of use, but we do always try to give that to our patients when anybody's having diarrhea, just to help balance the intestinal flora. Antidiarrheals, this is the appropriate dosing if you had to do that if your patient had diarrhea. You want to avoid anticholinergics with glaucoma, BPH, and you want to take caution in the elderly. You definitely, again, want to make those referrals. You may begin an initial workup and treatment in primary care and then refer to GI, especially if the patient is non-compliant or the therapy is not working for them. You want to follow up with the patient to assess their response to their treatment as well. Okay, celiac disease, what is it? Celiac disease, also known as gluten sensitive enteropathy or celiac sprue gluten sensitive. It is considered an autoimmune disease. It infects the small intestinal villus epithelium. It is an immune response to gluten and an exposure to cereal protein gluten or gliadin in wheat, rye, and barley. People are born with a genetic predisposition to this. T-cell mediated and humoral immune reaction. It's trigger reaction inflamed in the duodenum, jejunum, and ileum. And it used to be categorized as a pediatric disease because the majority of cases are now diagnosed in adulthood. Risk factors include a family history of celiacs, Down syndrome, HLA-DQ2 or HLA-DQ8, Turner syndrome or other genetic-based autoimmune diseases, and like type 1 diabetes mellitus and thyroiditis. It affects a haplotype HLA-DQ2 95% or HLA-DQ8 5%. Celiac patients have 3 times a risk of developing non-Hodgkin's lymphoma. Interesting. So in terms of subjective symptoms, they may be asymptomatic, or they could be complaining of diarrhea, weight loss, dyspepsia, flatulence. Atypical complaints include fatigue, which is usually a result from the anemia, joint pain, depressed mood, amenorrhea, difficulty getting pregnant, and early menopause. Objective, the physical exam may be normal, or they may have signs and symptoms of malabsorption, including muscle wasting, pallor, which would be a result of the anemia, reduced subcutaneous fat, ataxia, and peripheral neuropathy, usually from vitamin B12 deficiency. They may have a dermatitis herpetiformis, which is a cutaneous variant of celiac. It's in less than 10%. So this is a skin condition that celiac patients tend to get. Patients with dermatitis herpetiformis almost always have celiac disease on intestinal biopsy. Differential diagnoses includes IBS, IBDs, which includes Crohn's disease, ulcerative colitis, and microscopic colitis. Diagnostics include serological testing for anti-TTG and IgA antibodies, total IgA and upper GI endoscopic small bowel biopsy. Obviously, patients could try a gluten-free diet and then evaluate for symptom improvement. That's one way to handle it. The problem with that though is if your patient decided upon themselves to do that and just fast from anything with wheat, and then they come in to try to be tested to see if they're allergic, if they have celiacs, If they're already on a gluten-free diet, the blood work may actually come back normal. So you don't want to be trying to diagnose them if they've already been on a gluten-free diet. In these cases, gluten challenge can be attempted and the appearance of symptoms evaluated, as well as serologic markers are determined. You want to consider testing for malabsorption nutritional deficiencies, including hemoglobin, iron, folate, vitamin B12, calcium, and vitamin D. You want to consider a biopsy and a histologic examination. In terms of management with this celiac disease, you want to maintain a strict gluten-free diet. Again, we want to consider dietary or nutritionist referral who specializes in celiac disease. Of course, that's ideal. If you can't find that, then you need to refer them to like the celiac, website that is .gov. Find them some resources that will give them good lists, or maybe you can provide that in your office. Again, remember that risk of non-Hodgkin's lymphoma is decreased if they are able to maintain a strict gluten-free diet for over 5 years. So again, educate your patients. Like, you're reducing your risk of cancer or non-Hodgkin's lymphoma if you really maintain this diet. And they're also limiting their symptoms too. So it's a win-win for them. If they're lacking a robust response to the diet, work with the dietitian to review all sources of gluten, including medications, okay? Make sure your patient understands the sources of gluten. They may require aggressive treatment with immunomodulating agents. In terms of referral and follow-ups, you want to make sure you're monitoring them for complications or other diseases associated with celiac, which include Addison's Graves' disease, type 1 diabetes mellitus, myasthenia gravis, scleroderma, atrophic gastritis, and pancreatic insufficiency. Remember, guys, you guys are diagnosticians. You're going to be diagnosing. So you have to make sure you're conscious of the fact that patients with certain diseases are going to be at much higher risk for other diseases. So that's why we always give you these diseases associated with, or consider these differential diagnoses. You have to remember to think outside of the box. Bowel obstruction. All right, so bowel obstruction could be complete or partial. I'm sure you all have seen patients with this issue that can involve any segment of the large or small bowel. Simple bowel obstruction results from a mechanical blockage, or a functional, or also known as a paralytic ileus, can result from a disruption in motility. If it's acute, it's usually due to torsion, herniation, or intussusception. If it's chronic, it indicates a slow, gradual process, example, a tumor growth or strictures. High-risk patients include patients that have ingested a foreign body, any patients that have had prior abdominal surgery, any hernia, tumors, or diverticulosis. In terms of subjective symptoms and pathology, usually it's a sudden onset of colicky abdominal pain with nausea and vomiting. The pain is often intermittent and it corresponds to peristaltic waves, obstruction at the jejunum or below. It's brownish, fecal type vomit with initial bouts of diarrhea, soon followed by constipation. In the later stages of the bowel obstruction, they may have constipation and lack of flatulence. So remember, just because your patient is having diarrhea or little bouts of diarrhea doesn't mean they have good bowels. Like, they may actually be in the process of in the middle stages of a bowel obstruction. So just keep that in mind. In terms of small bowel obstructions, the pain is often at the umbilical or epigastric areas. Vomiting usually occurs early in the process. Arterial circulation is compromised, so the pain is more constant and severe. Vomiting and sequestration of the FNE can result in profound FNE imbalances, leading to dehydration, alkalosis, acidosis, hemoconcentration, and hypovolemic shock. If we have an increased distension and which causes diaphragm pressure decrease, respiratory volume, which causes atelectasis and pneumonia. Okay, so this is all important to know because a perforation produces severe generalized abdominal pain, as well as the classic signs of peritonitis. And if you don't know the difference, it could really cause you to make the wrong diagnosis at the time. So just be very conscientious of these differential symptoms that are presenting, to make sure you're diagnosing appropriately. Okay, pearls and red flags, super important. Older adults and abdominal pain. So just keep these things in mind. So anecdotally, Elderly often lack some robust pain response as younger patients and may be more susceptible due to the likelihood of having a history of previous bowel surgeries or tumor, placing them at risk for bowel obstruction. So be alert to signs and symptoms of mild abdominal pain, changes in their bowel habits, nausea and vomiting, and you always want to consider a bowel obstruction. Before just recommending a laxative for new onset constipation or a treatment for diarrhea, see the patient, examine them. This should be in your differential. So just remember, you want to get your hands on that patient's belly. You want to touch them, you want to listen to their bowel sounds, you want to see for yourself, what does their abdomen look like? Is it hard? Are they guarding? The physical assessment is really going to give you more information than just what the patient is telling you. So objectively, signs and symptoms will depend on the location of the obstruction and when in the process the patient presents. So you want to assess for abdominal scars. Again, you're looking at this patient's abdomen. You're looking for abdominal scars, hernias, signs of dehydration like poor skin turgor, dry mucous membrane, sunken eyeballs, and tachycardia. You want to see their vitals. The blood pressure is sometimes up depending on the degree of pain and if strangulation or if there's a subsequent ischemia. Your bowel sounds, you're listening to those before you start pressing on that belly, right? You're going to listen if they're high pitched or hyperactive, a positive or negative rushes coinciding with colicky abdominal pain. Could be a bowel obstruction due to strangulation. So in that case, you're looking for increased distension, abdominal tenderness, tympany to percussion, and hypoactive or absent bowel sounds. You may or may not feel a palpable mass. In terms of a perforation, you may have positive or negative periods of pain relief, followed by increased pain with rebound tenderness and fever. Consider fever, you're considering a systemic issue. It's suggestive of peritonitis. A bowel obstruction of the large intestine, we're looking at gradual onset symptoms for increased constipation and abdominal distension. So again, if it's in the large intestine, it's usually gradual onset of symptoms and abdominal distension. Remember, a large bowel obstruction is rare in patients younger than age 50. Okay, that's usually your older population. Painful lower abdominal cramps without stool may report several day history of no stools or flatus production. It could have or may possibly have or not have vomiting. Okay, the most common cause of large bowel obstruction is carcinoma of the sigmoid colon or diverticulosis. So keep that in mind. Again, we have to always think cancer. Abdominal plain film, supine upright, ladder-like distension of the small bowel. So these are our diagnostics in terms of a bowel obstruction. We want to look at upright films. We're looking for the hallmark of small bowel obstruction, which is multiple air fluid levels within the loops of the small bowel. We're going to look at oral contrast with small bowel follow-through to identify any areas of partial obstruction. Keep in mind, oral barium studies are contraindicated and must be avoided unless the large bowel obstruction has been ruled out. So the first thing you want to rule out is large bowel obstruction. So abdominal plain films of a large bowel obstruction, you want to get a distension of the intestine to the level of the obstruction. If there's air under the diaphragm, it's likely a perforation of the cecum or sigmoid colon has occurred. So here we have the x-rays, radiographs with a visual of the obstruction of the small bowel and then the obstruction of the large bowel. You see how this is starting to curve to the left? Remember, look at your landmarks when you're looking at your radiographs to really differentiate, what is actually wrong here? What's displaced? What looks abnormal? So bowel obstruction in terms of a volvulus. So an obstruction due to a volvulus is acute, causes a loss of blood supply, and later on subsequent ischemia. A cecal volvulus is a large gas bubble in the mid-abdomen or left upper quadrant, as you can see in the abdominal x-ray film. A sigmoid colon volvulus usually is only in older adults. It has a coffee bean dilation arising from the pelvis. And for both cecal and sigmoidal volvulus, a barium enema is done to reveal the precise location of the obstruction. So bowel obstruction. So here's a nice little chart with the differential diagnoses of the bowel obstructions. Um, in terms of labs, they're not diagnostic of themselves, but they do add to the overall diagnosis and of course help rule out other causes. So you're going to do your basics, your CBC, your metabolic chemistries, abdominal labs, LFTs, amylase, lipase, and then you want to calculate your anion gap. You want to check your lactic acid level because metabolic acidosis or an elevated lactic acid is highly suggestive of an intestinal infarction. And then in terms of management, you immediately want to refer to the emergency room, get a surgeon in there. They're likely going to need an NG tube, treatment for pain, vomiting, IV fluids, imaging, and surgery, depending on the findings. Okay, moving on into diverticular disease. Diverticular disease, in terms of diverticulosis, it's inflamed or infected would be considered diverticulitis. So remember, if it's just inflamed, it's diverticulosis. If it's an actual active infection, it's considered diverticulitis. Most are asymptomatic. Sometimes it's found incidentally on imaging, and it can become symptomatic if bleeding or becomes inflamed or obviously infected. Your greatest risk factors include people over the age of 40, patients with low fiber diet, any patients that has previously had an inflammation of the bowel or diverticulitis is likely to get it again. So once they get it, the likelihood is it will happen again. The number of diverticula present and any history of chronic constipation. These are all patients that are high risk for diverticular disease. It's most often seen in the sigmoid colon. Right lower quadrant presentation is a rare condition. We have a higher incidence in Asian populations. It's pretty equal between men and women. It's a rare finding in pediatrics. And again, it's a high risk if you are a person with a low fiber diet. So again, make sure you're educating patients with any kind of bowel issues about fiber and their dietary intake. In terms of subjective symptoms, it's usually left lower quadrant abdominal pain, which is worse after eating. The pain is sometimes relieved with a bowel movement or passing gas. You want to, the patients usually alternate between diarrhea and constipation. They may or may not have the abdominal distension and tenderness. They may or may not have bleeding, which may be massive and is not associated with pain or discomfort. Signs and symptoms of infection would be obviously fever, chills, and tachycardia. The patients usually present with localized pain and tenderness in the left lower quadrant of the abdomen, which is associated with anorexia, nausea, and vomiting. If a fistula has formed, the symptoms vary depending on the organs involved. The patient may complain of dysuria or pneumaturia, or passage of air in the urine, pneumaturia, and or fecal uria, which is passage of fecal matter in the urine. And if there is fistula formulation involving the bladder. So remember, if they see weird stuff coming out of the wrong hole, they're going to tell you. So that's how you know fistula has developed. All right, so just keep that in mind. Don't ignore them if they're telling you, hey, I'm peeing something weird, like, or it feels weird when I pee. Like, definitely investigate that further. Patients may be concerned about the development of hematochezia or frank bleeding from the rectum. Objective findings with diverticular disease includes tenderness in the left lower quadrant of the abdomen, firm fixed mass, which may be present, rebound tenderness with involuntary guarding and rigidity. Bowel sounds initially are hypoactive or hyperactive, and if an obstructive process has developed. Tenderness on rectal exam, stool is positive for FOB. Differential diagnoses could include IBS, carcinoma of the colon, IBD, lactose intolerance, pelvic inflammatory disease, ovarian cyst, colitis, appendicitis, and pyelonephritis. So again, guys, in terms of all these GI diseases, the objective, subjective, most of the symptoms are extremely similar. Do not be afraid to pull out your algorithms that we provided, especially in the last PowerPoint. You saw that there's a lot of differential diagnoses that go with the GI system. So just use those algorithms to really differentiate what your patients are dealing with. That'll really, especially when you're new in practice, that'll really give you confidence that you're really following the best standard of practice in terms of doing the best follow-ups and using tools that will really guide you. So diagnostics for diverticular disease include CBC, white blood cells. White blood cells are obviously increased in diverticulitis. Again, that's infection, so we would expect our white blood cell count to be up. It'll be elevated in abscesses, fistulas. H&H may be low with bleeding. If you're ruling out other causes, you're going to likely see the metabolic panel and other abdominal labs. Abdominal films you want to obtain in all patients with suspected diverticulitis so you can detect any free air, any ileus, or perforation. Really, with these x-rays, you're really just ruling out the major red flag differential diagnoses that could really lead to emergency situations. You can always get a CT with oral contrast if you want more specific, to be more specific. You could do a barium enema, but a colonoscopy really gives a definitive diagnosis. So management in uncomplicated diverticulosis, you can manage with a high fiber diet or daily fiber supplementation with psyllium. If the patient has mild symptoms, you're going to manage them outpatient. You're going to rest, have them rest their bowel. And how do you rest their bowel? You have them maintain their diet on a clear liquid diet. Literally, they just have clear liquids. That's all they eat. And that will allow their bowel to rest. Bone broth is something you want to recommend to your patients who are going through this kind of diet. If they need antibiotics, the appropriate antibiotics you're going to be prescribing are amoxicillin and clavulanate and potassium 875 over 125 BID, Flagyl 500 TID with Bactrim DS, orally BID for 7 to 10 days or until the patient is afebrile. Symptoms usually subside quickly, so keep that in mind. Tell your patient that when they start these antibiotics, the symptoms usually subside quickly. You want to advance the diet to a soft, low roughage, and then next to high fiber as tolerated. So if the symptoms do not subside quickly, you need to alert the patient that they need to follow up with you again because something else may be going on, or that we need to relook at the antibiotics we've chosen for them. So the choice of antibiotics depend on the severity of the disease process and should cover both gram-negative bacteria and anaerobic organisms. Pain due to spasms. Because of treatment, antispasmodics include Levsin, Bentyl, and Buspar. All right. If we're talking about acute illness, we may require a hospitalization, obviously, with IV therapy, antibiotics, hydration, analgesia, bowel rest, NG tube, and avoid morphine. It's usually, these patients usually experience relief after 72 hours of the antibiotic therapy, IV specifically, and they may resume oral intake as tolerated. Once they're able to maintain adequate nutrition and hydration, they can go home. And then they're going to want to have a follow-up colonoscopy to evaluate treatment once the acute phase has been resolved. If there's any complications with bleeding, they may require angiography to locate the site of bleeding. They may also require infusion of vasopressin during the radiographic procedure. If there are signs and symptoms of acute blood loss, obviously they may need a transfusion. And 20% of patients who have experienced a diverticular bleed will usually bleed again within a year. So these patients, you really have to give them a lot of education on diets to prevent diverticulosis, and which could lead to diverticulitis episode. So again, patient education, increased dietary fiber, when to follow up and watch for complications. You want to refer early on to GI if you suspect a need for a colonoscopy. Okay, so inflammatory bowel disease, not to be mistaken with irritable bowel syndrome. All right, two different things. Please make sure you differentiate them in your brain. Inflammatory bowel disease is a chronic immunologic disease which manifests in the intestinal inflammation. The two most common inflammatory bowel disease are ulcerative colitis and Crohn's disease, but microscopic colitis is increasing in prevalence and includes collagenous colitis and lymphocytic colitis. So it's interesting, when I was in grad school, these did not really exist. I mean, we talked about microscopic colitis, but the two most common really were ulcerative and Crohn's. We barely got into this. So now that time has passed, there's more research showing that it is increasing in prevalence. So we do want to make sure we are conscious of it as providers as we keep up to date with the latest research. So exacerbations and remissions are experienced throughout lifetime, which result in a significant disruption in the quality of life, obviously. Okay, so irritable IBD, inflammatory bowel disease. The risk factors include obviously genetics. Men and women both get it equally. The age at onset for ulcerative colitis and Crohn's disease is usually early adulthood and maybe ages 10 to 40. Microscopic colitis is more common in people over the age of 40. LC affects women and men equally, but CC is 20 times more common in women. Okay, so ulcerative colitis versus Crohn's disease. Now remember, we're talking about the umbrella of inflammatory bowel disease. And under inflammatory bowel disease covers ulcerative colitis and Crohn's, which are the two major ones, and then the microscopic. So first, let's get into ulcerative colitis. So ulcerative colitis involves only the mucosal surface of the colon, results in friability, erosions, and bleeding. It's often occurs most often in the rectosigmoid area, but may involve the entire colon, but not the small bowel. Crohn's is characterized by segmental or patchy transmural inflammation of the bowel wall involving any portion of the GI tract from the mouth to the anus. It has discontinuous skip lesions, and the disease of terminal ileus is present in about 80% of patients with Crohn's disease. So again, let's just look at the difference. We need to make sure we're able to differentiate these two diagnoses, very important. Crohn's usually happens at a little bit of an older age. The etiology is unknown. Crohn's disease is definitely exacerbated in patients that smoke. Again, that's usually in older people. Serologically, they're positive for the PANCA. So you're going to be doing your serological, looking at your serological results. You'll see with ulcerative colitis, if it's severe, they're going to get fever and malaise. Crohn's, you're pretty consistently malaise. Okay, weight loss is very common in Crohn's disease as opposed to ulcerative colitis. Rectal bleeding is very common in ulcerative colitis. So if you're hearing about rectal bleeding, you definitely want to consider that it's ulcerative colitis versus Crohn's. Pain is usually mild in ulcerative colitis. It's more pain in Crohn's for sure. And then rectal involvement is always in ulcerative colitis, only 50% of the cases in Crohn's. Okay, so in terms of the subjective symptoms in ulcerative colitis, there are three versions: mild, moderate, severe. So mild would be considered less than 4 loose bowel movements a day with abdominal cramps relieved with defecation, small amounts of blood and mucus in the stool. Moderate would be 4 to 6 stools. Severe would be 6 to 10 stools, also associated with, the abdominal cramps, possibly systemic symptoms in both moderate and severe. In Crohn's, your subjective symptoms would include abdominal cramping, tenderness, fever, anorexia, weight loss, spasm, flatulence, right lower quadrant pain, or mass. They always get increased symptoms when they have any kind of stress, emotional upset, after meals consisting of poorly tolerated foods like fatty, spicy, or milk foods. Stools are usually soft or semi-liquid. There's observable blood found intermittently, but it's much more frequent in ulcerative colitis. So honestly, if they're asking you questions about blood, you want to think ulcerative colitis as opposed to Crohn's. Because of the loss of healthy bowel mucosa, there may be insufficient reabsorption of bile salts causing steatorrhea. So you might get foul-smelling fatty stools with Crohn's. Crohn's disease can involve the entire thickness of the bowel wall, causing microperforations and symptoms of acute localized peritonitis. Okay, so objective findings in ulcerative colitis versus Crohn's. So ulcerative colitis is usually in the left lower quadrant versus Crohn's is in the right lower quadrant. All right. So you're going to assess for anal and perianal inflammation, rectal tenderness, and blood in the stool. You want to watch for symptoms of ileus and peritonitis in ulcerative colitis. There are 1 of 4 patterns of presentation in Crohn's disease. So you can go through those. It basically, as it gets worse, you get more of these presentations. It's usually uncommon in kids. And that's pretty much it for that. Okay, so diagnoses for both, for all inflammatory bowel disease include stool analysis and culture. Blood work would include metabolic, CBC, LFT, abdominal labs to help rule out other causes. Sigmoidoscopy. A colonoscopy should be avoided with severe colitis or deep ulcerations due to the risk of perforation, not to mention pain. You want to avoid a barium enema, again, due to the risk of precipitating toxic megacolon. We want to get some plain films. Obviously, differential diagnosis includes all of those other things we just talked about: C. diff, celiac, ischemic colitis, infectious colitis, drug-induced colitis, hypothyroidism, ulcerative colitis, and laxative abuse. Older adults, you want to consider anybody who has a history of coagulation disorders, and young women using oral contraceptives should be examined for ischemic colitis. And then, of course, colon cancer rarely presents with fever and purulent diarrhea, but it should be ruled out as a cause for bloody diarrhea. So management of IBD includes, so keep in mind there's no cure, but, and then when we start to treat, we always treat based on the severity of symptoms. So the goal is to reduce inflammation, correcting or maintaining FNE balance and the symptoms of the disease. So we want to get them on antidiarrheals because, again, we want to maintain that fluid and electrolyte balance. So how do we do that? We give them antidiarrheal so they'll stop having diarrhea, especially in the acute. You want to avoid it in the acute phase, but it is helpful for patients with mild symptoms. Mild to moderate diarrhea may benefit from Lomotil 2.5 to 5 BID and QID, depending on the severity, or Imodium 2 milligrams after each bowel movement. And then codeine every 4 to 6 hours, but that's if we're really having some problems. You want to look at table 40.3 to really look at all your different treatment options. Okay, I'm not going to read this to you. So with inflammatory bowel disease, with all forms, we want to watch for signs and symptoms of toxic megacolon and other sequelae. This all may require surgical intervention. We definitely have already started to collaborate with a GI doctor, especially if the patient is coming in more frequently with exacerbations or complications. Of course, they may require long-term steroids, immunosuppression, and frequent follow-up. Again, we've already made our referral to GI. We only do surgery if necessary, and after we've consulted with GI to make sure that we're all in agreement. Next is colorectal cancer. The majority of colorectal cancer is curable and preventable with early detection. So it may be symptomatic or asymptomatic, depends on the location. Usually it starts with polyps. They are the most benign forms of tumors. We have hyperplastic adenomatous and submucosal, which is your lipomas. Adenomatous polyps are precursors to malignant adenocarcinomas, and they comprise greater than 95%, are comprised of 95% of all malignant colon tumors. Over the past 20 years, there's been a decline in mortality rate associated with colorectal cancer attributed to improved screening, including diagnosis and treatment, but those colonoscopies really do prevent cancer. CRC cure rates are estimated up to 50%. So when we catch it, it is very, very curable. We just have to catch it in time and actually go through the treatment. So the risk is usually age is the most important risk factor for developing CRC in the US. It's rare in less than age of 35 unless there's genetic risk factors or a genetic family history. It's equal in men and women, although men are greater than women in rectal cancer. African-American males and members of low-income minority groups have lower survival rates, which is presumed, although not proved, in part result of inequalities in access to healthcare screening and treatment. Personal history of adenomatous polyps, which is multiple polyps or individual polyps greater than 1 centimeter in size, or colon cancer also put you at higher risk. Disorders involving increased colon mucosal cell turnover, such as TBD and UC, Lynch 1 and Lynch 2 syndromes, and high fat, high animal protein, low carb, low fiber Western diet definitely puts you at higher risk, obviously, which if you're on that kind of diet, obviously you're talking about obesity, physical inactivity, smoking, and then of course, any excess of alcohol, more than 2 drinks a day also puts you at high risk for colorectal cancer. So in terms of staging, the classifications of colorectal cancer are really important for you guys to know. As with all cancer, there are different stages depending on the metastasis, the tumor, and the node. So just be conscious of stages 0 to 4. And, in terms of stage 4, they have distant metastasis and they have less than a 5-year survival. Okay, CRC, in terms of colorectal cancer, most colorectal cancers are adenocarcinomas. It involves getting a colonoscopy, looking at polyps. You want to evaluate those polyps. You got to remove the entire lesion for cytological examination. If the polyp is less than 7 millimeters in diameter, the tissue for the biopsy can be obtained while the polyp is destroyed through hot biopsy or fulguration. If there is metastatic progression, it's spread by local invasion, lymphatic extension with spread to the mesenteric lymph nodes first, and then it has hemogenous spread through the portal system to the liver. You may see metastasis through the peritoneal cavity and lungs. Rectal carcinoma spreads by direct extension through the perirectal fat to the lymph nodes and less often to the lungs and distant organs through hemorrhoidal circulation. The prognosis of colorectal cancer is really dependent on a poorly differentiated tissue histology, mucin production, DNA abnormalities, tumor invasion to other organs, perforation, and venous involvement. The prognosis is not influenced by the tumor size, which is interesting. In terms of subjective data, it depends on the location. Usually there's melena or bright red rectal bleed, change in bowel habits, stool streak with blood, abdominal pain, and then tenesmus, or urgency. Objectively, it depends on the location. You may be able to palpate an abdominal mass, or if they have a large liver, you want to consider metastasis. The DRE is usually normal. Blood testing is positive in 60 to 70% detected with FOBT. In terms of diagnostics, you're looking at your CBC for any anemia. We're checking CEA for CRC, LFTs for liver metastasis. The colonoscopy establishes the diagnosis of CRC with almost 100% accuracy, and it's the diagnostic procedure of choice. So if we're considering colorectal cancer, we need a colonoscopy to really confirm the diagnoses. Flexible sigmoidoscopy confirms lesions within the rectosigmoid area. However, full colon examination with colonoscopy is preferred. So this just gives you a different area, a better view in a different area. CT scan is evaluation of distant metastasis, and then an endoscopic ultrasound. It stages the regional rectal cancers and is more accurate than the CT scan in this particular area. Differential diagnoses of colorectal cancer includes ischemic colitis, diverticular disease, IBS, IBD, or infectious colitis. Any patient presenting with anemia over the age of 50, if the stool is positive for occult blood, if they have a change in bowel habits, or hematochezia, should have a thorough evaluation to rule out the possibility of a neoplasm. So in terms of managing colorectal cancer, first thing first, we need to stage it. The only known cure for colorectal cancer is surgical resection, and the type depends on the type and location of the tumor and cancer. Non-resectable rectal cancers can be palliated with a diverting colostomy. They will have to undergo chemotherapy and radiation, and they will need a GI specialist, preferably the one who performed the colonoscopy, but they're also going to probably need a surgeon, an oncologist, and now an ostomy specialist. This is not a fun thing for these patients to go through, so please make sure you are giving them as much support as you can. Refer to any kind of counselor, mental health clinician if this patient is having a hard time managing, because to suddenly have an ostomy, especially at this stage of life in their 50s, 60s, is a game changer for these patients. And a lot of times they get very depressed, especially in the beginning when they have to first learn how to manage it. So you really want to offer them as much education, resources, and support as you can that they have access to. Primary prevention, obviously, is a colonoscopy to prevent having these issues. We want to watch for updated guidance in terms of the CDC and their recommendations for patients depending on their age, change in age and the first screen, etc. You want to review and make recommendations with their patients during their annual physicals and refer to the GI specialist as indicated. So this is from 2009. Remember that the US task force sets out these guidelines as to when and how often colonoscopy should be provided to your patients in terms of screening recommendations. You want to make sure you keep up to date with these particular recommendations because this is the standard of care that we are upheld to. And based on these recommendations, the patient's insurance will also cover this. So it's a great screening tool that is covered by most insurance companies that you should offer your patients. Not everybody will do it, but you should always make them aware that it is available. Okay, so now we're getting into the gallbladder. Cholelithiasis, which is gallstones, versus cholecystitis, which is gallbladder inflammation. So in terms of subjective data, usually you'll have a generalized GI complaints to intractable pain, usually right upper quadrant. The patient is complaining of indigestion, nausea, vomiting, especially after consuming a a meal high in fat. Usually they have referred pain that radiates to the mid back, infrascapular, or right shoulder, and the pain is increased by any kind of movement. Objectively, it reflects the degree of inflammation present in terms of the patient's level of pain. You're going to have a positive Murphy sign. The gallbladder will be palpable in about 50% of patients. A lot of them have low-grade fever, and a high fever suggests sepsis. So be very conscious of that. Remember, any kind of fever or high fever or tachycardia, we're thinking systemic issues. The patient may also exhibit some mild jaundice. Hyperbilirubinemia should raise the suspicion of cholelithiasis. Bowel sounds also may be diminished. You want to look at the diagnostics. Remember, for gallbladder issues, ultrasound is the gold standard of diagnosis. So make sure you get that ultrasound. Abdominal films are useful, a HIDA scan, a CT scan if you are concerned there's a perforation, or if you suspect necrosis. We definitely want to check CBCs, bilirubins, LFTs, amylase, lipase, and metabolics. If there's an increase in amylase, there's probably a stone passage to the CBD or gallstone pancreatitis. You definitely want to get an EKG if you're considering cardiac in origin. I would just get an EKG immediately. If you're doing an ultrasound, do an EKG. Differential diagnoses include pancreatitis, myocardial infarction, appendicitis, peptic ulcer, pneumonia, and hepatitis. Management, we want to, if it's acute cholecystitis, usually will subside spontaneously with improvement in the first few days and resolution of symptoms after about 4 days. If the symptoms persist or become more severe, the potential for perforation, gangrene, epipemia, and septic shock increases. Rebound tenderness, shaking, chills, or increased fever should raise suspicion that perforation has occurred. Surgical referral is indicated early in the disease process. So if any patients coming in with any kind of gallbladder issues, immediately let's get them connected with GI and then obviously a surgeon if necessary. In terms of managing this, we want to avoid gangrene, perforation, or septic shock. So definitely educate your patients on symptoms of, systemic infection. We want to consider non-surgical dissolution therapy called lithotripsy if they are not a surgical candidate. Consider that these patients may require hospitalization for IV fluids, NPO imaging, or antibiotics. In terms of imaging, you want to look for any stones, obstructions, and thickening of the wall of the gallbladder. Patient education definitely includes, again, dietary counseling in terms of weight loss if the patient is obese, avoidance of fatty foods that provoke attacks. Patients on any oral contraceptives should be given information about alternative forms of birth control, and menopausal women taking estrogen should be counseled about alternative sources of phytoestrogens such as soy products. Okay, getting into acute pancreatitis. We're going to be talking about acute pancreatitis versus chronic pancreatitis, the causes, diagnostics, differentials, and the management of it, okay? Approximately 80% of all admissions for acute pancreatitis are the result of biliary tract disease or passing of a gallstone or alcoholism. The patient may become extremely ill, including shock, renal failure, respiratory compromise or ARDS, and hypoxemia. Pancreatic necrosis with secondary gram-negative sepsis has an associated 100% mortality rate unless there is extensive surgical debridement of the infected tissue. Not a good thing. Certain common and uncommon medications may cause pancreatitis. So, big thing that you need to be aware of as a practitioner is what can cause pancreatitis. So look at your box here, 41.1. What are we looking at that can cause pancreatitis? So infection, hyperlipidemia, metabolic disorders, drugs. These are the particular drugs: furosemide, sulfonamides, thiazides, and valproic acid. An ERCP could cause pancreatitis. Structural abnormalities of the pancreatic duct could cause that pancreatitis, structural abnormalities of the common bile duct and ampullary region, surgery, particularly of the stomach and biliary tract, valvular disease such as atherosclerosis and severe hypotension, and then, of course, trauma. Now, what does it look like? What are we seeing in these patients with acute pancreatitis? We're seeing an abrupt onset of intense, deep epigastric pain that persists for hours to days and may radiate straight through to the back, often refractory to large doses of IV narcotics, aggravated by vigorous activity, coughing, lying supine, improves when seated and leaning forward. These patients appear acutely ill. They may or may not have nausea and vomiting. They may or not be sweating, anxious. They may report a history of ingestion of alcohol or a big meal before the onset of symptoms, or mild biliary colic preceding the episode. Objectively, they're going to have some severe abdominal tenderness, particularly in the epigastric region. They may or may not have guarding, but it would be without rigidity or rebound tenderness. We're going to see milder pain in the lower abdomen without guarding or rigidity. Abdominal distension is present in approximately 20% of these patients. Excuse me. Bowel sounds can be hypoactive or present if paralytic ileus. And the stool is usually negative for occult blood. They can be tachycardic with rapid, shallow respiration. The inspiratory effort is poor because of the pain in their abdomen. Blood pressure is usually elevated due to the pain, or it's decreased if shock is imminent. Sometimes the temperature is normal, but it can increase to 100 to 102 within a few hours. Mild jaundice and sclera icterus may be present. The skin is pale, cool, and clammy if shock is present. If you will have specific findings if it's due to a pancreatic inflammatory response, which includes bluish discoloration over the flanks. Know your gray Turner sign. Again, I'll repeat that. Bluish discoloration over the flanks, that's considered your gray Turner sign. Or you have bluish discoloration over the umbilicus, the belly button, that's considered Cullen sign. This is considered pancreatic inflammatory process. These are the symptoms you're going to see. Obviously, jaundice would be caused by impingement on the common bile duct, and an epigastric mass may be secondary to a pseudocyst development. So in terms of diagnostics, your gold standard is an elevated serum amylase level up to 3 times normal. However, in 1/3 of patients with alcoholic pancreatitis, the serum amylase level may be normal. So just keep that in mind. Know your patient's social history and what they're like to, how much they're drinking. Diagnosis is supported by a concurrent elevation of serum lipase. You're going to have your CBCs, LFTs, chemistries, bilirubins. You're going to look at you're going to probably have an elevated C-reactive protein. You're going to get a CT with guided aspiration of the necrotic tissue for gram staining culture if it's indicated. The CT is also helpful in differentiating acute pancreatitis from other fatal intra-abdominal processes, which is helpful in monitoring the progression or resolution of the pancreatic pseudocyst. Contrast may be helpful. You definitely want an ultrasound to help differentiate diagnoses, and an ERCP is helpful to see stones in the biliary tree. But remember, here's your gold standard, so you always want to start with that, because that's the basic standard of care that is expected as for you to draw for this particular diagnosis as a nurse practitioner. Differentials you want to consider in terms of acute pancreatitis. So remember, anybody of childbearing age, you definitely want to consider a ruptured ectopic pregnancy. Get a pregnancy test on those females. Opioid administration. Know your patient's medications. What are they taking? Or do they have any addiction issues or history of? Okay, management of acute pancreatitis. So you're going to use Ranson's criteria to determine the severity and the need for hospitalization and ICU care. So you don't have to guess like, oh my God, this patient is so sick. What do I do? Like, do they need to be diagnosed? I don't know. Well, here is a very standardized tool that will guide you and also validate your need to hospitalize a patient. All right, and you'll definitely be documenting that you use this particular tool in your documentation to make note that this is the standardized tool you used to qualify your patient for hospitalization. In terms of managing the patient in the hospital, they're going to likely be hospitalized for pain management, IV fluids, electrolyte management, imaging, debridement, and surgical referral. Mild cases might be manageable at home. It's difficult to treat pain and keep fluid status up to par while maintaining NPO. So just keep that in mind. Patient education, they may need a cholecystectomy. Obviously, they're going to need referrals to the ER if it's acute. They're going to need a GI specialist and a surgeon. Obviously, you're going to be teaching your patient again about reducing their dietary intake of fat, alcohol abuse. They should be encouraged to abstain completely. Patients with a genetic hyperlipidemia require diet instruction and information on avoidance of precipitating factors, such as alcohol, estrogens, and certain drugs. If a drug is a suspected cause of the pancreatitis, it should not be restarted, okay? Chronic pancreatitis, so that usually presents with chronic abdominal pain, weight loss, exocrine insufficiency due to malabsorption, and diabetes mellitus. You're going to see weight loss and diarrhea. They may have mild dyspepsia, nausea, and vomiting. The pain may precede other symptoms of chronic pancreatitis by years, often precipitated by or aggravated by food or alcohol intake. A lot of 50% of these patients you're going to see also have diabetes. So just keep in mind these diagnoses are very closely associated. And it's often the presenting sign individuals have no pain associated with pancreatitis. So steataturia develops after the pancreas loses the ability to secrete digestive enzymes, which results in bulky, foul form smelling fatty stools. So that's going to be a clear indication that we've got something going on with the pancreas. They also often complain of oil leakage from the rectum or an oil slick in the toilet bowl, which is indicative of pancreatic insufficiency. Objectively, the patient might complain of mild to moderate epigastric tenderness with no rebound tenderness or guarding. They may have a palpable abdominal mass, which is suggestive of pancreatic pseudocyst. Bowel sounds may be present in patients with paralytic ileus. Lung sounds may be diminished in the bases, indicative of pleural effusion. In terms of diagnostics, you want to get abdominal plain films, a CT, and an ultrasound. Blood work will include endocrine and exocrine function testing, urinary excretion of pancreatic chymotrypsin, and or a secretin stimulation test. Just keep in mind ERCPs are associated with an increased risk of acute pancreatitis from the dye injection. So just be conscientious of that. Differential diagnoses include diseases that present with persistent abdominal pain, like peptic ulcer disease or mesenteric ischemia. Diseases that result in weight loss and abdominal pain also include abdominal malignancies, especially pancreatic cancer. Remember, we talked about weight loss and cancer. Intestinal disorders that present with steataturia, or that fatty, oily stool. Diagnosis of chronic pancreatitis can be confirmed with visualization of the calcified pancreas on X-ray films, which will also rule out most other disease processes. Okay. Management, obviously we want to prevent further pancreatic damage. We want to manage the pain and supplement exocrine and endocrine function. As a major cause of chronic pancreatitis is alcohol abuse. We want to make sure we're educating our patients that complete abstinence is imperative. Pancreatic enzyme supplementation may relieve pain in some patients. Narcotics are usually necessary to manage pain. Pain is not managed by analgesics or pancreatic enzyme therapy, should be considered for operative treatment. And then a low-fat diet of less than 50 grams per day and oral GI endocrine specialist referrals. We want to make sure that these patients, if they need it, they have the fat soluble vitamin replacement of A, D, E, and K, which may be required. So again, more management of these patients. Remember, most of them are diabetics, 50% of them. So we want to make sure they're maintaining their serum glucose levels of 200 to 250. Do not overeat, which can cause hypoglycemia. Do not overtreat, because it can cause hypoglycemia. We want to correct poor nutritional habits because of malabsorption and malnutrition and the elimination of alcohol. Normal insulin requirements range from 5 to 15 units daily up to 40 units per day. It is best to maintain these patients at a higher than normal glucose level to avoid hypoglycemia while avoiding significant glucosuria. They may need surgery if they're to drain persistent pseudocysts because it'll relieve pain as well as treat other complications associated with chronic pancreatitis. Okay. Okay, so it was important enough to include this. So in terms of patient education, so patients with chronic pancreatitis, they need to be taught about the pathophysiology of this chronic disease, common complications, and the long-term outlook. They can expect that after 5 to 10 years, the episodes of pancreatic pain will diminish in frequency and may disappear. Patients should understand their medication regimen, including appropriate timing of medication doses and adverse effects. Patients tend to be more compliant when they understand the goal of treatment is to control diarrhea and gain body weight. Patients can be provided with written instructions to assist with adherence. Patients should be cautioned against long-term narcotic analgesic use because it can result in drug dependence. If they need, obviously, they need to be referred to a pain control clinic if they're having issues with pain. Okay, next, the next big one and last is cirrhosis. This is the last thing. We're almost done, guys. But very important. So try to stay with me. Cirrhosis. This is so huge because of the amount of alcohol in this country. Alcoholic cirrhosis is the most common type of cirrhosis in the United States. Other causes include severe acute injury, example, hepatitis caused by HBV, HCV, obstructive biliary diseases, or from chronic continuous abuse, as seen in alcoholic cirrhosis, which we can see on table 42.1. It's irreversible. End stage of liver injury is caused by a variety of insults, including fibrotic scarring, hepatocellular changes result from chronic inflammation, obstruction, and toxic metabolic and congestive injuries. It classified according to histological changes, which includes micronodular and macronodular. Okay, subjective symptoms of your patient who has cirrhosis of the liver, which would include weakness, anorexia, weight loss, fatigue, malnutrition, and upper GI bleeding from the esophageal varices, which develops secondary to portal hypertension. As cirrhosis progresses, the patient develops ascites, or that big abdominal distension, and or encephalopathy, where they become like confused and just very, they're losing their memory. They get abdominal pain due to the enlargement of the liver and stretching of Glissen's capsule or by the ascites. They get menstrual abnormalities, the females, loss of libido, impotence, sterility, and gynecomastia due to the increased estrogen from the liver's inability to inactivate the hormones. It's not a pleasant sight to see these patients. These patients who are end-stage cirrhosis are really in a lot of pain, and it's very sad to see how they progress. Objectively, the abdomen is huge. I mean, you can use this nice little word enlarge, but their abdomen is huge. They look like they're about 9-10 months pregnant. A lot of them are also very thin at the same time, anorexic because of the poor absorption, and poor appetite. So you'll feel firm liver edge at the left lobe, which is palpable below the right costal margin. With advanced disease, the liver may be small and difficult to palpate. Obviously, we could be suffering from splenomegaly, esophageal varices, hematemesis, hematochezia, and or melena, including hemorrhoids, which result from the portal hypertension, are also present and can cause bright red bleeding from the rectum. In terms of their skin, you're going to see the spider nevi, the pectoral alopecia, generalized muscle wasting, palmar contractions, parotid gland enlargement, palmar erythema, hair loss, testicular atrophy. They could be getting fevers, hepatitis, jaundice, sclera. Mucous membranes usually develop in the later stages of cirrhosis. Pruritus, bruising, and they have an easy tendency to bleed. And you'll see a lot of them have peripheral edema. Mild confusion to coma as they have increasing blood ammonia, which is toxic to the brain, of course. They get a lot of tremors, deep tendon reflexes, hyperactive deep tendon reflexes, dysarthria, delirium, and drowsiness. Diagnostics include CBC, macrocytic anemia, and pantocytopenia. Coagulations, you're going to see an elevated PT. Your liver function tests are obviously going to be elevated. Classic finding is mild to moderate increase in the ALT to the AST. In alcoholic cirrhosis, you're going to see AST to ALT ratio ranging from 2 to 1 to 3 to 1. Liver biopsy can differentiate cirrhosis from hepatitis. You want to get an ultrasound to stage where we're at, and a CT and MRI can also be helpful. In terms of differential diagnoses, mostly the same as the list of etiologies. The management, of course, is to aim and identify and remove the causative agent, treat the symptoms, and prevent complications. We're referring to a GI doctor and or hepatologist, and obviously a surgeon is needed. If it's alcohol, we need to abstain from alcohol, start multivitamins and some other vitamins that are probably the patient is deficient in, including B12, folate, thiamine, magnesium, and zinc supplementation. If they're alcoholic, if this is a result of alcoholism, you want to question whether this patient would be need a transplant and would they be appropriate for a transplant. If it's chronic and irreversible, these patients will need a liver transplant. If it's primary biliary cirrhosis, we're going to need to get them on vitamin supplements, immunosuppressives, and consider surgery. For hemochromatosis and Wilson's disease, we need to consider blood products, reduce the copper, and transplant and surgery. And then vascular or congestive liver disorders, we need to consider, of course, blood thinners and surgery. So these patients are very complex patients. They have a potential for multiple manifestations of disease and complications. They require frequent follow-up and coordination of care with specialists. And you always want to consider at a certain point, definitely getting these patients in the very early stages to fill out their advance directives, talk with their family members, caregivers, their healthcare proxies, make sure they have advance directives in place, because the likelihood is these patients will end up on palliative or hospice care, especially end stage. So you really want to get their advance directives in place as quickly as possible, just to give these patients the opportunity to make their own decisions. Because remember that encephalopathy starts kicking in, and then it's very difficult to be clear with them as to what they want. Advanced liver disease, many complications and sequelae. We have hepatopulmonary syndrome, hepatic encephalopathy, which is the accumulation of ammonia. And here we want to avoid a high protein diet with these patients. We have hepatorenal syndrome, where we want to watch the urine output, the BUN, and the creatinine. We have spontaneous bacterial peritonitis. And then, of course, we have bleeding. Varices, rectal, they easily bleed from the gums, lacerations. Remember, if you remember, the liver is responsible for the clotting factors. So if the liver is shutting down, we start to lose that. And that's it, guys. You got through it. I'm so proud of you. I hope this was a helpful PowerPoint presentation. And I hope you have a great week. And I'll see you next week. Thank you so much.